I'm Dr. Koen Deloose. I'm a vascular surgeon and head of the Department of Vascular Surgery here in AZSint Blasius in Dendermonde, a small city in Belgium. So, you know, we are living today in a world where there is a lot of treatments based on drug-eluting technologies. And I'm 100% an enthusiast of drug-eluting technologies. But I notice in my daily practice, and especially also in the more complex lesions, that I also still need a lot of bare metal stents. I'm thinking, for instance, as a bailout post-drug-coated balloon use. We all know the more complex the lesion, the more bailout stenting you need. And also quite recently and confirmed in the capsicum trial coming from Japan, we noticed also if you have a very laborious recanalization process, subintimal, bidirectional, antegrade, retrograde, big loop, subintimal, and so on, we notice that probably the use of drug-eluting technologies can create aneurysm formation or the important degeneration of the vessel wall. And so in these kind of situations, I also try nowadays to avoid the use of drug-eluting technologies, and I switch again to bare metal stents. And so in these particular indications, I think that the use and the need for a modern generation of bare metal stents is really a very important issue. Yes, so in this context, if we are speaking about a modern generation of a bare metal stent, bare metal nitinol self-expandable stent, well, then we need some important characteristics. Of course, visibility is for me extremely important. If we want to do a precise placement, you need to see your stent, at least without using too much X-ray and radiation. Secondly, if there is, for one or another reason, not an optimal placement, well, it should be nice if you can reposition your stent. So recapturing the stent and reposition it in a better way. Of course, we all know that a good balance of forces, I'm thinking on the crush resistance, on the radial resistive force and the chronic outward force, is of course an absolute must in a modern generation of bare metal stent. We need to have a broad range of sizes available. And I notice also in congresses, in live cases, that more and more physicians are using distal embolic protection devices, not only in carotid disease, but also in a peripheral arterial disease. Well, if we can have a device that is also implementing let's say, kind of embolic protection, would be very great. And when we are taking all these characteristics together, we are coming out in the specific Renzan stent. So an interwoven nitinol self-expandable stent of Terumo, where there is also a dual layer available. A micro mesh is in the inner side of the stent in order to avoid protrusion of material through the struts of the stent and avoiding distal embolization. The stent is perfectly repositionable. It's a monorail, it's a rapid exchange stent delivery system. What is very comfortable, there are extremely good markers on the stent and in the undeployed state and in the deployed state. And in my opinion, for an interwoven stent, we know there is a competitor on the market with a quite complex delivery system if you are not used to it. Well, here you have the classical push and pull delivery technique where it is rather easy to deploy the stent in the correct way. The repositionability is present here with this device. So I think it is fulfilling all the characteristics that I summarized earlier during this question. So with this particular Renzan stent, there was the initiative of Terumo to set up a prospective multi-center post-market single-arm study to confirm, of course, the performance of this Renzan peripheral stent system in patients with femoropopliteal disease. The endpoints in the trial are a safety endpoint, freedom from death, TLR, any amputation of the index limb at 30 days, and a primary efficacy endpoint in terms of primary patency defined at 1 year, core lab controlled. The goal of the study is to enroll 135 patients all over Europe in 15 European centers. All patients, actually claudicants and also critical limb ischemia patients up to Rutherford 5 are allowed. Lesion lengths between 4 and 14 centimeter in terms of length, and 4 to 7 millimeters in terms of diameter. So these are the most important, of course, beside a bunch of other in and exclusion criteria, but nothing special related to a FemPop study. These are the most important, let's say, definitions in the PRIZER study. So right at the moment, there are 68 enrollments out of the planned 135. And so at the 1st of July, we made a snapshot, let's say, of the first 60 patients that are enrolled in the study. And so we have patient lesion characteristics in this first cohort, preliminary cohort of 60 patients. In terms of lesion characteristics, we are talking about lesions of almost 7 centimeters in length, what is quite classical for this type of studies. A reference vessel diameter of 5.6, completely normal in the femoropopliteal tract. And we notice also, let's say, the presence of calcium in 50% of the cases. When we are looking at the, let's say, the patient characteristics, we notice that the majority of the patients are severe claudicants, but there is also a substantial amount of, let's say, critical limb ischemia patients. 18% of these first 60% cohort is a critical limb ischemia Rutherford 5 patient. And so when we are diving into the data, we have two types of data. First of all, patient level data, where we notice that we reached a safety endpoint at 30 days, freedom from death, TLR, or limb amputation in 97% of the cases. So 58 patients were doing extremely well. There was one death due, unfortunately, to the malignant COVID-19 infection, and there was one TLR due to an acute stent thrombosis and revascularized afterwards. There were also some other procedure-related complications. There was one distal embolization without any, let's say, negative influence or consequence for the patient. It was treated with thrombus aspiration in a very efficient way. And there was also one major bleeding at the access site, a major in terms of requiring transfusion, but at the end also no major issue afterwards for the patient anymore. On the other side, beside the patient level data, we have also the technical level data, let's say. We asked all the interventionalists to, let's say, to judge the stent deployment in terms of pushability, easiness of deployment, the visibility of the stent, the precise placement, and the radial forces. And so we noticed that in the majority of the cases, the technical judgment of the interventionalists and the enrollers was extremely well, with perfect visibility in the majority of the cases, easy deployment, very good pushability without resistance. So the initial data on the technical field are also very optimistic. Well, of course, we have only the data now in 60 patients, so a relatively small cohort, also with a relatively short follow-up. I need to see the efficacy at 1 year in a substantial cohort of patients. But if these data that we notice now in terms of safety, in terms of the easiness of use of this device, are confirmed in the further enrollment during this PRIZER study, well, I think then we have a new kid on the block. We have a fantastic interwoven stent that is very easy to implant, that is predictable where you implant it, that is repositionable, and that is also answering the need for protection against distal embolization. So for me, it's going to be also, again, a new generation bare metal stent that is entering in a safe and efficient way in the market, a market where there is still the need for the use of bare metal stents. But as I've mentioned, one condition, if these preliminary results are confirmed on the longer run and in the bigger cohort, the 135 patients in the PRIZER study. Well, the next steps, of course, as I've mentioned, we continue with this PRIZER study up to the 135th patient. We try to have a perfect follow-up and perfect ECRF platform so that we have all the information on patient level data and on technical characteristics. And once this is confirming the preliminary data we have, then I think we need to extend the population that we are treating. I've mentioned in the beginning, in an exclusion criteria discussion, we have lesions between 4 and 14 centimeters. Of course, this is not my daily practice. I want to have also a device that is working in 20, 25, 35 centimeter lesions. So I think the next step is to open it to an all-comers registry and to see if we can use this fantastic Renzan stent also in daily life practice.